Alright, good day everybody. Today we'll be talking about a special topic, anatomy of the urinary bladder. Okay, so if you've not liked my video, if you've not subscribed, if you've not commented, please do so. Help my channel to grow and God will bless you real good. Amen. So we're gonna talk about this particular guy using this outline. We're gonna be as brief as possible, I promise. Okay, so start with introduction. The urinary bladder is a muscular bag that serves as reservoir for urine temporarily before it is excreted through the urethra. Then we go to the location of the urinary bladder. The bladder is located in the pelvic region, but when it is full, it comes up to the abdominal region. Okay, that is why when you want to perform suprapubic cystomy, you use the method suprapubic cystomy, that is above the pubic cystomy removal of stones and what have you that has taken over the bladder. You don't go to the pelvic region because that will be a lot harder. What you do is to distend the bladder with fluid or something like that, so you can be able to access the bladder in the abdomen that is above the pubic region. Okay, so that's by the way. So that's location of the urinary bladder. We have the size and capacity. Average capacity of the urinary bladder is 220 milliliters. 220 milliliters. Then we have the shape. The shape varies depending on its state. If it is full, it will become ovoid shape. If it is empty, it becomes tetrahedral or pyramidal. Pyramidal because it presents an apex and a base pyramid. Then you can also say tetrahedral because it has four surfaces. Have the superior surface, the two inferior surfaces, and then the posterior surface, also known as the base or fundus. Then we have the features or parts of the urinary bladder. These are what immediately you find the urinary bladder. There are some things you see externally, the gross features. So we have the apex, the neck, the base. We have the borders. These are the lateral borders. 1, 2 lateral borders that separate the inferior lateral surfaces from the superior surface. We have the anterior border that separates the two inferior lateral surfaces. We also have the posterior surface here. Okay, and you can see that the superior posterior angle, the superior superior posterior angle is where the ureter pierces into the base of the bladder. Okay, that's by the way. So we have talked about the features and parts. We now talk about the relations of these various parts. We take it one by one so as not to mistake anyone or leave anyone out. This is the apex. The apex, you can see, is related to this fine guy, which is the median umbilical ligament. This is the obliterated urachus. Failure of this urachus to obliterate will form the urachal fistula. There is an open communication between the bladder and umbilicus. In such a situation, you see urine coming out of the person's umbilicus. Scary, right? Yes. So we don't want that to happen. So the urachus, which is a part of the allantois, has to go, obliterate. You can say shrink, okay, and form this median umbilical ligament. That's the relation of the apex. It's found in both males and females. Don't worry. Okay, so we go to the next one, which is the neck of the urinary bladder. The neck of the urinary bladder is related to different structures in males and females. Why? Because females don't have prostate. So in males, the neck of the bladder is related to the prostate gland. So this prostate, you can say it's the median lobe of the prostate, but normally say it's related to the prostate. Go your way. Then in females, what is it related to? Instead of this prostate, we have the urogenital diaphragm. Good. Then we go to the base or the fundus. The base of the fundus, you see, superior laterally is the ureter. So it's related to ureters coming from the kidneys in both male and female. Okay, then in males, it is related to the seminal vesicle and retrovesical pouch, which contains coils of small intestine, not found in females. And then it is also related to the rectum, which is also found in both males and females. So in females, it's related to the uterus comes is superior, so it comes makes angulation before it continues as your vagina, and you have your cervix too. So the base of the bladder in females is related to the vagina and cervix. Then we've talked about this. We now talk about the superior surface. Superior surface of the bladder relates to different structures in both males and females. In females, because there is this uterus, that's the womb, superior to this surface. It's in females, it is related to the superior to the uterus, and the uterus forms a pouch here, which is known as the vesical uterine pouch. This vesical uterine pouch is now related to the superior surface of the bladder in females. In males, there is no uterus, so we have the cords of the small intestine, the peritoneum, and sigmoid colon. And also note, in males, the superior surface of the bladder is completely covered with peritoneum, but in females, it is not completely covered with peritoneum. Rather, it has a part that is not covered, which is the supravaginal part, the part above the vagina. Yeah, of the part of the bladder above the vagina is not covered in peritoneum. So we have the inferiolateral surfaces. Okay, the inferiolateral surfaces is related to the pubis. Okay, so this is the retropubic space. So in both male and females, there is a retropubic space related to inferiolateral surfaces and the pubis, but in males only, because there is no prostate in female. In males, we have the puboprostatic ligament, which serves as the floor of this retropubic space though. But in males, the puboprostatic ligament is also a structure related to the inferior surface. Okay, remember that is urethra here. This guy is urethra. URETHRA, urethra, related to the neck of the bladder too, in both males and females, because males and females have urethra. Right. So internal, we talked about the ligaments. Okay, the ligaments are, there are true ligaments and false ligaments. True ligaments are formed from thickening of the pelvic fascia. They serve as supportive function, but the false ligaments, they are from peritoneal folds. They form peritoneal folds. Okay, so they do not serve any protective function. So we're talking about the true ligaments. They are very important. The median umbilical ligament is one of the true ligaments, which connects the apex of the bladder to the umbilicus. We've talked about that. And then we have the puboprostatic ligament in males, which connects the pubis and the prostate. And we also have the pubovesical ligaments, which connects the neck of the bladder to the pubis bone. Okay, it's found in both males and female. We also have the posterior ligament, which is very important because there is a venous plexus inside this posterior ligament known as the vesica. Okay, vesica venous plexus. Okay, so once you dissect the posterior ligament of the bladder, you find your vesica venous plexus. Then we have the lateral ligament that connects the lateral surface of the bladder to the pelvic wall. This connects, the posterior ligament connects the base of the bladder to the pelvic wall. So we're done with ligaments. We now go to the internal structures. Internal structures, when you dissect your bladder open, what do you see? You see muscular folds called rug. Okay, a lot of muscular folds, but significantly there is a part of the bladder where you don't find these muscular folds, which is called the trigon of the bladder. This is very important, trigon of the bladder. In fact, the trigon of the bladder is bounded superior posteriorly by the two ureters and inferiorly by the urethral orifice, because we have one urethral orifice but we have two ureters, so we have two ureterial orifices. That is for the superior boundary of the trigon of the bladder, and that's very important. Arterial supply. The arterial supply of the bladder is supplied by arteries near it. We have the superior vesical artery, inferior vesical artery. In females, we also have the vaginal artery, the uterine arteries, and then we also have minor arteries like the gluteal arteries and the obturator arteries. Gluteal and obturator arteries. But the major ones are superior vesical, inferior vesical, and which are branches of the internal iliac arteries. So we have venous drainage. This the arteries do not, veins do not follow arteries. So we have, remember I told you posterior ligament contains the vesical venous plexus. Okay, so this drains into the internal iliac vein. Okay, lymphatics. The lymphatics of the urinary bladder, they all drain, the lymph nodes surrounding it drain into the external iliac vein. Remember, external iliac vein, majority. Then few now drains into the internal iliac, external iliac lymph nodes. I meant to say external iliac lymph nodes. That is where majority of these lymph nodes surrounding the urinary bladder drains into, whereas the other ones, which are few, now drain into internal iliac lymph nodes. We now go to the nervous supply. Nervous supply of the urinary bladder. It's supplied by the vesical plexus of nerves, which is sympathetic, parasympathetic, sensory, and even somatic. So very, very important. The muscles of the smooth muscles of the bladder is known as the detrusor muscles. The parasympathetic gives motor to the detrusor muscles. They contract and it relaxes or inhibits the sphincter muscles. So once these detrusor muscles contract, it forces urine out of the sphincter, which is inhibited by parasympathetic nerve supply. And the parasympathetic nerve supply comes from S2 to S4 spinal segments. That causes urine outflow. But sympathetic inhibits urine outflow by giving motor to the sphincter muscles and relaxing the detrusor muscles of the bladder. Okay, so that is for the nervous supply, very important. So the clinicals, we know that once there is an obstruction here, urine can't pass through, it becomes trapped here. Once it is trapped, this guy expands and becomes trabeculae, so that is trabeculated bladder. So once the urine passage is blocked, urine outflow is blocked, and you cannot pass out urine, the bladder becomes trabeculated. Okay, so have nervous, neurogenic bladder. So the neurogenic bladder, in the sense that there is something wrong with the parasympathetic or sympathetic nervous supply, in the sense wherever the problem is coming from will lead to the loss of function of that particular part. If it is the parasympathetic supply, you know that you're not going to be easing yourself very well, because it's responsible for the expulsion of urine. If it's sympathetic, that means urine control will be a very big problem. That is all. I think I have done justice to this quick revision. Please remember to like and give encouraging comments. If you know how we can improve, please also tell us. Thank you very much. Remember, it's